Hello, this is Robert Lee, and this is a brief video on radiotherapy and the treatment of muscle-invasive bladder cancer. The 2020 NCCN guidelines make it clear that in patients with clinical T2 to T4 invasive bladder cancer, concurrent chemoradiotherapy is a viable option with equivalent survival rates. Probably the one study you need to know is from Nick James, published in the New England Journal in 2012. Basically, it's a trial comparing radiotherapy or chemoradiotherapy. So plus or minus chemotherapy, the fractionation regimens, as you see there, 55 and 20, or 64 and 32 per fraction. 5-FU is given day 1 to 5 and day 16 to 20. Mitomycin is given day 1. Just one dose of mitomycin. There is no split, and the whole bladder is treated the whole way. This is the primary endpoint. Local disease-free survival is improved with the addition of 5-FU and mitomycin to radiotherapy alone. This, however, did not result in overall survival benefit, although the trial was not powered for that endpoint. Other studies that are relevant through the years, the RTOG has done almost a dozen chemoradiotherapy trials. The results of some of these trials were pooled a few years ago and published in JCO. 10-year overall survival for patients on all of these studies was 36%, which compares favorably with radical cystectomy. The disease-specific survival, as you see there, and bladder intact disease-free survival is about 55% at 10 years. As you might expect, T2 tumors do better than T3, T4 tumors, both in overall survival and disease-specific survival. And again, as you might expect, complete responders do better than non-responders, but non-responders do have disease-specific survival approaching 50% at 5 years. These are 10-year estimates from the pooled analysis. The local recurrence is about half. Invasive local recurrence is only about 14%. Most of the local recurrences are non-invasive and can be treated with further conservative therapy not requiring a cystectomy. Lymph node recurrence about 15%, and distant metastasis about a third of patients by 10 years. A more recent randomized comparison of two different regimens, RTOG 0712. I want to hasten to point out that this really isn't a randomized comparison. It's the way to think about it is parallel phase 2s. Patients were randomized, but the study was not designed to be able to discriminate between the two treatments as to which one is superior. This is taken directly from the methods. It was not statistically powered to compare regimens, but to assess whether either regimen exceeded a distant metastasis-free benchmark of 75% at 3 years. Bottom line is both of them did. The primary endpoint is freedom from distant metastasis-free survival at 3 years, and both of the regimens met that criteria. Hematologic and GI and GU toxicity, very small numbers of patients in each group, but no clear differences. And the authors concluded that both regimens demonstrated efficacy above what they had hoped. They did see slightly fewer toxicities in the gemcitabine and daily radiation arm, but they concluded either one is appropriate. This is looking at long-term toxicity in the GU realm, about 5% at 5 years. GI toxicity much less than that, well under 5% at 5 years. It's important to try and do a TUR, maximum TUR, if possible, the results are better if a complete TUR can be accomplished. This is not surprising. Finally, the urodynamics. This is again from the MGH, about 200 patients with a follow-up, median follow-up of 6 years. Essentially 80% of them had a compliant bladder with minimal or no urgency, and quite surprisingly about 50% had normal erectile function after radiotherapy. Patient selection is paramount. The best patients have T2, T3 disease, good bladder function. If the bladder function is poor, it doesn't make a lot of sense to try and preserve. No hydronephrosis, no extensive CIS, and no prostate invasion. Patients should understand that they require frequent surveillance after treatment with chemoradiation. So the take-home points for muscle-invasive bladder cancer treated with radiotherapy: it's really a good example of trimodality care. Has been approved by the NCCN and the European Association of Urology. Roughly 2/3 of bladders are spared. For the most part, those patients with retained bladders have reasonably good urinary function, and it remains an option for the motivated patient. Here are the resources. Thank you.